So now let's see a case vignette. Now read this. A young male presents with backache, gets up in the morning, goes through the morning rituals, और उसके बाद he starts feeling somewhat better. What is this disease? क्या चीज? ऊंची बोलो अगर तुम्हें मतलब even if you don't know. Yes, so ankylosing spondylitis is a strong possibility in this patient. The classical history is that a young male presents with morning backache, moves around, feels slightly better. Now, what are seronegative arthropathies? एक RA factor negative rheumatoid arthritis भी होती है ना? So seronegative arthropathies are generally in which there are markers of autoimmunity which are not present. There are other features as well कि rheumatoid arthritis को आप कैसे diagnose करते हैं? The patient has certain criteria जो आप American Rheumatology Association या European Rheumatology है उसके जो criteria हैं उसके accordingly diagnose करते हैं. So there are some features on which you can distinguish these seronegative and seropositive arthropathies. Classically, these arthropathies are without serological markers. लेकिन arthropathies serological markers के अलावा ये भी होती हैं, इसके अलावा और भी कौन सी होती हैं? जो आप कह रहे हैं ankylosing spondylitis group है, इसके अलावा और कौन सी होती हैं? You got non-inflammatory arthropathies. Inflammatory arthropathies है ना, इसके अलावा seronegative non-inflammatory arthropathies भी होती हैं, like degenerative diseases, osteoarthritis. Is osteoarthritis an inflammatory condition? Why do we call it osteoarthritis? Arthritis means inflammation. Why do we call it osteoarthritis? Traditionally, शुरू से चल रहा है, थोड़ी बहुत inflammation होती है, injury की वजह से inflammation तो होगी थोड़ी बहुत. So these are basically degenerative diseases, and they usually are limited to joints which are weight bearing, या जहाँ पे repeated stress या trauma होता है. So knee joints हैं, hip joints हैं, lumbar spine है, sometimes in cervical spine as well. अगर आपको बाजू बहुत ज़्यादा इस्तेमाल करें, आपका पेशेंट है तो shoulder joint में हो सकती है. So these are the arthropathies which are usually limited to weight-bearing joints or joints which have repeated trauma and then you've got crystal deposition diseases. They are also monoarticular and they are inflammatory. इसी तरह हम infective arthritis को भी कह सकते हैं because there is inflammation when there is infection. And again, they are limited to 1 or 2 joint at the max. So ये बीमारियां ऐसी होती हैं जो जिनको हम traditionally non-inflammatory arthropathies में रखते हैं. Inflammatory arthropathies which are seronegative are the spondylarthropathies. Now, what are spondylarthropathies? Spondylarthropathy का मतलब क्या है? Which involves the vertebra or the spine. क्या इन spondylarthropathies के अलावा कोई और बीमारी spines को involve कर सकती है? Seropositive arthropathies joint को involve करती हैं spine के? क्या चीज? How would rheumatoid arthritis involve spine? ये जो spondylarthropathies होती हैं, basically they are a disease जहाँ पे muscle, ligament, bone से लगे होते हैं. वहाँ पे ये trouble create करती हैं. So, for example, sacroiliac joint जो है एक fibrous joint है. Now, how the rheumatoid arthritis involve the spine? Because spine में जो rheumatoid arthritis है, this is a disease of synovial joints. Where are the synovial joints in the spine? कौन से? Atlantoaxial joint. Synovial joint होता? जो facet joints हैं, facet joints हैं ना, जो transfer process के ऊपर facets लगे होते हैं, उनके joints हैं, they are synovial joints. So, RA can have involvement of the spine. लेकिन again we can differentiate these on other features. कि उसमें और synovial membranes involved होती हैं. In arthropathies में spinal जो synovial joints हैं वो involve नहीं होते. So the key features of seronegative inflammatory arthropathies are, number one, they are negative for RA factor. और ये classically हम पहले ना जब definition शुरू में बनी थी तो ज़्यादा auto antibodies का हमें पता ही नहीं था. इसलिए हम इसको कहते थे कि इसमें RA factor negative है. But now we know that all other markers of autoimmunity are absent. Like ANA absent है, citrullinate peptide absent है, या DNA absent है. So इन बीमारियों में ये markers negative होते हैं generally. So it's negative for markers of autoimmunity. It has a strong association with HLA-B27. This group of diseases are also called HLA-B27 group of diseases. 90% जो AS है, ankylosing spondylitis, उसके साथ association होती है HLA-B27 की. लेकिन HLA-B27 की base पे आप diagnosis नहीं बनाते. Diagnosis बनाने के लिए हम दूसरे criteria use करते हैं because 10% may be negative. They still have ankylosing spondylitis. They're usually negative for acute phase inflammatory markers or have only mild elevation. जैसे हम autoimmune disease में देखते हैं inflammatory markers बहुत ज़्यादा होते हैं, ESR, CRP. इनमें rise करते हैं लेकिन इतने ज़्यादा नहीं होते जितने, लेकिन again इसकी बुनियाद पे हम diagnosis नहीं बना सकते कि inflammatory markers थोड़े से ज़्यादा हैं, बहुत ज़्यादा नहीं है तो ये seronegative arthritis होगी. Seropositive भी हो सकती है. So these are the general features of these seronegative inflammatory arthropathies. Now, what are different type of spondylarthropathies? Ankylosing spondylitis is the prototype and the classical example. Then you've got psoriatic arthritis, you've got reactive arthritis, you've got enteropathic arthritis, you've got undifferentiated arthritis. So these are different type of spondylarthropathies. The prototype is ankylosing spondylitis. बाकी सब मौजूद होती हैं लेकिन उनका prevalence कम होता है क्योंकि inflammatory bowel disease के साथ सब लोगों को आर्थ्रोपैथी नहीं होती, psoriasis में भी सब लोगों को आर्थ्रोपैथी नहीं होती. But ankylosing spondylitis itself is a disease entity, इसके साथ और कुछ नहीं होता, ये बजाते खुद एक बीमारी होती है. So we don't have any other associations with ankylosing spondylitis. There are extra articular manifestations, but there are not other associations with this ankylosing spondylitis. जैसे psoriatic arthritis के साथ you got skin lesions. Now, what are the manifestations of inflammatory arthropathies? There are musculoskeletal manifestations, there may be extra articular manifestations. Now, there are joint pains. Classical example is backache. Now, what are the features of backache? We've already discussed. This is a lower back pain. Patient gets up in the morning, there is muscle stiffness. The spine feels very stiff, and as the patient moves, the inflammation starts improving. Well, this is quite different from osteoarthropathies, the osteoarthritis. When the patient gets up in the morning, patient is slightly better. There may be some pain, but generally it's not that stiff and that pain. And all arthropathies which are degenerative, they generally tend to improve with the rest, while this disease worsen with the rest. There is involvement of larger peripheral joints, and these joints may be asymmetrically involved. Maybe involvement of the hip, shoulder, elbow, this wrist, ankle. So they are not symmetrically involved as happens in rheumatoid arthritis. There are smaller joints as symmetrically involved. So this is different. One variety of psoriatic arthritis is very, very similar to rheumatoid arthritis, presents in a very similar way to rheumatoid arthritis. When we go into the detail of psoriatic arthropathy, we find there are 5 different types of presentations. One of them is just like rheumatoid arthritis. This is enthesopathy. This is the hallmark of this disease. What is enthesopathy? Wherever muscle or tendon joins the bone, there is inflammation at that place. This place is called enthesis. The classical example of enthesis are Achilles tendon, patellar tendon, and plantar fascia, radial styloid, all places where ligaments attach on the vertebral edges. The vertebrae are connected with the spinal ligaments. So these places are all inflamed. So this is what is called enthesitis, classical hallmark of this seronegative arthropathies. Then you've got dactylitis. The spellings are not correct. This is not dactylix, this is dactylitis. This is sausage-shaped finger, inflammation of the finger. And then you've got extra-articular manifestations. There may be manifestations other than the musculoskeletal joint, even in ankylosing spondylitis. In other diseases we see there are associations with gut, for example, patients who have got inflammatory bowel disease, they may have diarrhea and bleeding and abdominal symptoms. But in ankylosing spondylitis, you have extra-articular manifestations as well. For example, there is inflammation in the eye. There is anterior uveitis. Whenever a patient comes with anterior uveitis, one should look for the presence of ankylosing spondylitis. Generally, if the patient has these eye disease, they have manifestation of the joint disease as well. But some of the patients may not have this temporal relationship. The joint disease may come after the eye disease. So eye surgeons, when they see this anterior uveitis, they always consult a physician that could this be a manifestation of this sort of rheumatological process. Skin, you can have psoriasis. Psoriasis is seen as, you would have studied skin, huh? Haven't you? Skin के lecture नहीं हुए अभी तक? External, जो हमारी extensor surfaces हैं, they have got this rash. They have involvement of the nail as well. So you may have a rash of psoriasis and erythema nodosum. Where do you see this erythema nodosum? Shin, or it can also be seen on the dorsum of the forearms. In which disease? Inflammatory bowel disease. So you may see inflammatory bowel disease, you may find erythema nodosum. Cardiovascular disease, you may have aortitis and different conduction defects. Aortitis can result in aortic regurgitation and formation of the aortic aneurysm as well. So the patient may have the consequences of this. Then gut, patient may have bloody diarrhea and other abdominal symptoms depending upon its ulcerative colitis or it is Crohn's disease. And then in ankylosing spondylitis, you may have this apical fibrosis. And there may be restrictive defect. What is this restrictive defect? Do they have pulmonary fibrosis? Apical fibrosis is different than generalized pulmonary fibrosis. Do they have pulmonary fibrosis or something else? The joints become ankylosed, so the chest cannot expand. So they present with a restrictive defect on spirometry. May have metabolic bone disease. And there may be neurological defects like cauda equina syndrome. There's compression of the nerves emerging at the lower end of the spine, and they may develop amyloidosis in long-standing disease. I remember a patient when I was registrar, an old man came in. He had swelling of the feet. And when we found on examination, there was a large amount of protein passing in the urine. So he had developed nephrotic syndrome. And on further assessment, we found that he had ankylosing in the neck. The spine was not much involved in other areas, but there was ankylosing of the spine. And a biopsy was done which showed that the patient had renal amyloidosis. So you can have these consequences of long-standing diseases if they're not managed well. Now, presentation we have already discussed. There is backache, there is fatigue, and there is decreased functional capacity. There are constitutional symptoms. Patient may have fever. Some of the patient may have weight loss. There may be organ-specific extra-articular manifestations we have already discussed. So this is the presentation of ankylosing spondylitis. Pain is at night. Onset is slow. Symptoms generally start before the age of 40 years. And there is improvement with exercise. So these are the features of backache. There is no improvement with rest as occurs in mechanical type of defects. So the patient has this presentation. Now, this is the classical presentation of an advanced ankylosing spondylitis when joints are ankylosed. यार ये पूरा शो डाल रहा है. You see, this is a question mark sign. There's a pot belly. You see, neck is flexed, and when you ask the patient to stand alongside the wall, touching the heels to the wall, patient cannot touch the occiput with the wall. So there is a restriction in movement. So this is classical posture. And this is a picture of dactylitis. And this is classical enthesitis. This is a psoriatic patch. Whenever you have patients who come with joint disease, always examine the nail, the scalp, the natal cleft, the umbilicus for the presence of this patch. This may be present only in limited area. It may not have an extensive presentation of psoriasis. So whenever a patient has this sort of asymmetrical joint disease, backache, look for the presence of this rash in areas I already told you. Look into the scalp, look into the natal cleft, the umbilicus, back of the ears. So these are hidden areas where this rash may be present. Now this is modified Schobar's test done in Medical Unit 2 of Services Hospital. Now see how do we do. What does Schobar's test tell us? Is it specific for ankylosing spondylitis? What do we find out with this test? The limitation of the movement of the lower spine. Is the lower spine movement restricted or not? Classically seen in spondylarthropathies. This can be present in other arthropathies, but it's classically seen in spondylarthropathy. Now we see how we do this test. Now we mark the dimple of Venus. Do you know what's the dimple of Venus? It's the dimple visible on the back and it represents posterior iliac spine. We mark those, we draw a line, horizontal line between these two marks. Then we take the center of these two marks, that's the midline. Always use pencil which is erasable. Don't use permanent markers on the patient. Then you draw a vertical line, a mark 5 centimeter below this and a mark 10 centimeter above this. So it's a 15 centimeter line. So what you do when the patient flexes, this line stretches. So you see how much the 2 points separate when the patient is flexing. So this tells us that this lumbar spine is fixed and is not flexing, the stretch of the skin. So it should be more than 15 centimeter. Kitna lenge Yasir? If it is more than 5 centimeter, it's normal. If it is less than 5 centimeter, it means there is some restriction. And generally with ankylosing spondylitis, we find in majority of patients, it's just 1 or 2 centimeters. So there restriction of the spinal flexion. Diagnosis is clinical and radiological. That inflammatory markers, HLA, B27, they do not give you a diagnosis. A clinical presentation, the patient has backache with morning stiffness, which improves with activity, involvement of other joints. Sacroiliitis, this is the hallmark of diagnosis. This is usually symmetrical in ankylosing spondylitis. It may be asymmetrical in other type of arthritis. That is, one side may be involved and the other side may not be involved. But in ankylosing spondylitis, generally both sides are involved. Routine X-ray can tell us about the erosions and sclerosis present in the sacroiliac joints. In advanced cases, they may be completely fibrosed and obliterated. In initial phases, CT and MRI may help. If there is a recent disease, there is a mild disease. The MRI may be useful. It tells us the inflammation. The bone marrow may be edematous. There may be bony erosions. There may be new bone formation. and there may be fat infiltration. So this may be seen on MRI. So generally, we do not require these. Its clinical presentation is usually sufficient enough for us to make a diagnosis. But when we are confused and the X-ray is negative, we can go for an MRI. Would we go for an HLA-B27? I don't think it is useful. The imaging are more diagnostic than HLA-B27. So MRI can pick very mild and minor disease as well. So if we are confused, we can go for an MRI, but generally this routine X-ray is sufficient. We don't need anything else. We just need a good image of the sacroiliac joints that tells us this is ankylosing spondylitis or there is sacroiliitis present. And then we can find enthesitis. Now, do we require any imaging for enthesitis? Generally not. You see the tenderness that at that area, it tells you that there is inflammation. What can be the reason for tenderness? One is inflammation, the other is injury. If you sustain an injury, you can have this enthesitis. So an X-ray can tell us there is erosion of the bone, there is squaring and roots of anterior curve of vertebral bodies. That gives the picture of bamboo spine, which is seen in ankylosing spondylitis. It is less common in other type of seronegative spondylarthropathies, but classically seen is in ankylosing spondylitis, and this is because of the enthesitis and following ossification. And then you can use power Doppler ultrasound, which can tell us the presence of inflammation by showing us the increased vascularity and flow and edema at the place of enthesis. But generally, as I mentioned, we do not require. Clinical diagnosis in almost all cases is good enough. So you can rely on your clinical judgment that this is enthesitis. Labs, there may be high inflammatory markers, ESR, CRP, but they may not relate with disease activity very linearly. They do not go in a linear fashion as happens in seropositive arthropathies. Markers of autoimmunity are generally absent. HLA-B27 helps support the diagnosis in patients with spondylarthropathies, but as I mentioned, if you've got radiological evidence, you don't need any other investigation. So this is an expensive business. What's the cost of HLA-B27 in the market? It's around 4,000 to 5,000. So we don't need it. An X-ray is going to cost how much? A good X-ray may be costing 800 or 1,000 rupees. So it's 4 to 5 times more expensive. So we don't need this test. But just keep in mind when there is confusion, you can have an assistance from this, but generally we do not require this. Treatment is pharmacological. You can use non-steroidal anti-inflammatory drugs, sulfasalazine, TNF-alpha inhibitors like etanercept, adalimumab, infliximab, etc. So you can use these TNF inhibitors. You can use corticosteroids. Corticosteroids are generally not used. Why corticosteroids are not used? This is an inflammatory disorder. These are long-standing diseases. If you want to use steroids for longer terms, they are going to result in Cushing syndrome, iatrogenic Cushing syndrome. And there are a few other problems reported with steroids, like avascular necrosis. So we do not generally use steroids in these patients. May be required in certain situations. For example, steroids may be required in the eye. When the patient has uveitis, may be required there. So generally, we do not use steroids for the management of these diseases. But you see, they may be required, for example, if you want to control the flare of inflammatory bowel disease. These may be required. But generally, for ankylosing spondylitis, we do not use steroids. Now we've got newer drugs, like Janus kinase inhibitors, the JAK inhibitors. This is tofacitinib. So we can use, and tofacitinib is available in the market. It's a cheaper drug. Yes, we use it. So you can go and see this in our rheumatology clinic. So we use this. कितने का है ये? So it's cheaper than these TNF inhibitors. And then you got another group of drugs that is interleukin-17 inhibitors, like secukinumab. We are also using this secukinumab as well. So these are pretty good drugs which can control the disease, and we may require some assistance from the physiotherapy department, and then some patient with advanced disease may require surgical assistance. For example, they may require vertebral osteotomy when there is ankylosis and the nerves are trapped, so we may require osteotomy. We may require fracture stabilizations, because these patients, they tend to have more fractures. Why they tend to have more fractures? One we mentioned, there is presence of metabolic bone disease. And because of their limitation in movement, they tend to have more falls, so they can have more of fractures than general population. And then in some patients, we may require joint replacement. So these are the general management strategies.